That every year we publish something called the Facts and Figures Report. And again, if you go to alz.org/facts, that will take you to that document. And it really is used not only nationally but internationally as the trusted resource around where we are with this disease. Next slide. So just to give you a couple of these facts and figures, we know today there's more than 5 million Americans, 65 plus, living with Alzheimer's disease. And unless we have some sort of disease-modifying drug or some sort of a cure, we know that that number is going to triple to nearly 3 times that by 2050. It's currently the 6th leading cause of death in the U.S., and it's the 5th leading cause of death for those 65 or older, or for women at any age. So every year with our Facts and Figures report, we publish a special report as an addendum to our Facts and Figures report. This year's report was focused on looking at primary care physicians. And as you can see, about half of those say they really don't believe the medical profession is really prepared to meet the demand of the increase of the number of people with dementia in the coming years. Next slide. This just gives you an example of some of the charts and graphs that are part of the Facts and Figures report. And as you can see, by state, you can see the projected increases between 2020 and 25 in Alzheimer's dementia. So you can see how some states are going to be affected by this more than others. Next slide. And let's talk a little bit about the toll that this has on caregivers. And so for this slide, we're talking about those non-paid caregivers, the families and friends that are providing care. And we know that in 2019, more than 16 million Americans provided an estimated 18.6 billion hours of care, and that care is valued at $244 billion per year. We also know that the lifetime cost for someone with dementia is now over $350,000 for their lifetime costs, which is really just a staggering amount. Next slide, please. And who are those Alzheimer's caregivers? Well, over half of the primary caregivers take care of their parents. And then about a quarter of those are those sandwich generation caregivers. So they're taking care of not only an aging parent, but a child as well. We know that about 2/3 of caregivers are women, and we also know that about 2/3 of persons with dementia are women. So this is an issue that is particularly important for women. And about 1 in 3 caregivers is over the age of 65 or older, and 41% of those caregivers have a household income of $50,000 or less. So if you think about the slide before that talked about the lifetime cost of someone with dementia is over $350,000, and you look at the 41% of caregivers have a household income of $50,000 or less, you can see that those numbers just don't add up. Next slide, please. And then looking at the side of paid healthcare. So if you look at the cost in 2020 of where we estimate the cost of caring for people is projected to be $305 billion. That's up from about $290 billion from last year. So again, we keep continuing to see the cost to increase. And then remembering that that does not include the $244 billion in unpaid care. So if you take that $244 billion and you add it to the 305, you can see that today in 2020, between paid and unpaid care, we're spending over $500 billion to care for people with Alzheimer's and other dementia. Next slide. So on the paid side, so then where does that money go? And as you can see, a vast majority of it, over half goes to the Medicare program, and then another percentage goes to the Medicaid program. So a vast majority of that is for people getting care and being paid through the Medicare or the Medicaid program. And so who funds that? We do as taxpayers. You know, that's really, I think, important for us to remember that we fund those programs, and a vast majority of that is coming through those two programs. Next slide, please. So today we're going to be talking about emergency preparedness guidelines, but I wanted to let you know that as we developed these guidelines, we grounded those, and you'll have to hit, I'm sorry that we've had some animation in this slide, so if you just will have to hit enter a few times till it scrolls down on the left side. There you go. Thank you. when I came to the association almost 5 years ago, I knew one of the things that I was going to be involved with was updating our dementia care practice recommendations. And we've had guidelines really since the 80s. Our most current version was about 10 years old when we updated these. So we decided to take a little bit different tack with those. We really, as you know, in working and being involved with the association, everything we do, we want to make sure that there's evidence. Certainly, on the medical science side of the house, around all of the work we're doing with the scientific community, is certainly grounded in evidence. And we wanted the same thing to be true with care and support. So we held some focus groups. We did a literature review to see how the evidence had changed over the past 10 years with our previous recommendations. And then my colleague, Dr. Sam Fazio, and I, who co-led this project, went out and worked with the leading researchers in the country. And we had 10 primary authors and then 17 other researchers. We developed 10 topic areas of these recommendations. We asked each one of these researchers to develop a journal article for the gerontologist based on their topic area, and then develop 5 to 7 recommendations at each one of those topic areas. And then we roll those recommendations up, 56 of them, and those now are the dementia care practice recommendations from the association. And they really provide the foundation for how we believe dementia quality care should be delivered across long-term and community-based care. Next slide. So this slide gives you the topic areas. As someone who's worked in that culture changing world for 20 plus years, it's really exciting for me to say that the Alzheimer's Association firmly put our stake in the ground to say it really has to have a person-centered care focus. And then those other topic areas that flow from that are detection and diagnosis, assessment and care planning, medical management, information, education and support, dementia-related behaviors, activities of daily living. And I can tell you on those, we started out thinking we would only have one article around ongoing care, but based on the amount of evidence that really had been produced in the past 10 years, we split those up into 2 areas. The next is workforce. The final is supportive and therapeutic environments. And then finishing up with transition and coordination of services. I think it's also important to remember that these recommendations are for all paid healthcare professionals working in nursing homes, assisted living, home care, home health, adult daycare, any home and community-based setting. We feel these recommendations are applicable. Next slide. So when COVID-19 struck, we started thinking from the Alzheimer's Association, how could we be helpful? We know that the providers and the provider associations, rightly so, were focused on prevention activities and focused on infection control and focused on working to keep their workforce stable. But we also know that a vast majority of people in all settings, and you can see the numbers here, and these come from our facts and figures report, in every setting have a great percentage of people that they serve with dementia. My guess is that these numbers are probably on the low side, but from the reporting, that's the numbers that we have. We also know that in emergency situations, it presents special circumstances. And during this time, that more than likely, there's going to be non-clinical staff that are going to be needed to help in the care and support, or maybe staff from a different department, or maybe staff from another healthcare setting. So we felt it was really important to start working on these guidelines to have as a resource for the provider community. Next slide. So I want to just briefly today go through the main topic areas. Again, if you go to alc.org/COVID, alc.org/professionals-COVID, that will take you to the link that'll get you the full documents. But we wanted to start and just remind folks, along with everyone else, that there's important things that need to happen to prevent illness. And, you know, one of those is hand washing, and we hear about hand washing all the time and the importance of that. But we really wanted to emphasize that as well in this document. Personally, several years ago, I was fortunate enough to be part of a workshop that went around the country talking about infection control. And it was primarily a nursing home audience, although we did have some assisted living folks there. And I would say one of the biggest ahas that we took away from that experience was the staff really had pretty good protocols around washing their hands. But what we realized almost uniformly across the 30 cities that we took this workshop to was they really didn't have a good protocol around washing the hands of the residents. Even in one observational study we used, they noted that sometimes residents were going 40 hours without having their hands washed. We know with COVID-19, the most important way that we can help in breaking the chain is by hand washing. We also know that residents with dementia may not be able to do that or do that properly. So, we're hearing examples of communities having a hand washing schedule. And now that there's non-communal dining, sometimes having the person that's delivering the meal to have an opportunity to talk to make sure the resident washes their hands, but also to help them understand that depending on where someone is in their level of dementia, they may not really know how to do that. So the staff needs to know how to model that behavior with each person that they're working with. And then also just remembering, this is a good time to remember to use a little bit of moisturizer. Skin integrity is so important with the elderly, and we know that the drying agents and a lot of these antibacterial soaps can really be harmful to the skin. So after making sure that residents have their hands washed, making sure that they use a little bit of moisturizer as well. I'm not going to spend a lot of time going through all of these areas, but I would just say another one that we hear a lot about is social distancing. But, the other thing that I hear from, and I would love to hear from you today in the chat feature, and let me just say, please utilize that chat feature as we go through, because we've left enough time with our presentation today to hear from you, either with challenges that you're having, but we'd also like to hear some successes that you're having as well. And this social distancing, especially for those people in memory care units, can really be tough. So if any of you has figured out ways to manage that and working with persons with dementia, we would love to hear about that. Next slide. So again, the reason that we developed these guidelines was we know that many times you're going to have staff that may not be used to providing this type of care. For instance, I've heard a lot of different types of stories. For instance, someone shared the other day that the person that used to drive their van now is an activity person. The van's really not going anywhere. So they've repurposed his job responsibilities to have him work on helping with the social isolation piece. We also know that people living with dementia really do better in a routine environment, and they can become more confused or frustrated or even display an increase in dementia-related behaviors during this type of a crisis. And again, now that we're weeks into this, we would love to hear from you to see if that's the type of things that you're experiencing and what as well. Next slide. So again, everything goes back to a person-centered care approach. And so we wanted to just stress the importance, again, of person-centered care. And I'm just going to run through quickly the recommendations from our dementia care practice recommendations. And it starts with knowing the person. We really believe if you don't have a process in place to know the person, then you really aren't going to be able to provide the type of quality care that you should be able to. We know that we've all been working on this for many years. I sort of grew up in this long-term care world with the old model, the staff-directed model that really practiced efficiencies on how best to accomplish care. But we now know that's not the right way to do it. We really have to have a process to where we know the person and then we honor the person and we plan our care around that. We also have to remember that after we know the person, that we recognize and accept that person's reality and understand that that might not always be our reality. And I think that's really important to remember in these type of emergency situations we're in now. And when you do that, then that allows you to identify and support the ongoing opportunities that you have for meaningful engagement, which allows you to build and nurture those authentic relationships. And when you do that, then you really do create and maintain a supportive community that's really putting the person first, but it also empowers the staff as well and really makes them feel more engaged and that they're doing their job in a better way. And then evaluating care practices and regularly make appropriate changes. As you could hear from some of the initiatives that I've been fortunate to be involved with over the past few years, it's really a lot of it has been focused not only on person-centered care, but also on quality improvement. And again, we know that in the acute care settings, through the work with Joint Commission and looking at adverse events and root cause analysis. That's something that's pretty common language in the acute care world, but it's newer for us in nursing homes and in assisted living. But it's really important to have a measurement process in place, because the only way that you're making a difference is to do some sort of a plan, do, study, act process where you look at an issue and then you make changes based on your findings. And then the other one that we wanted to just highlight was advanced planning. This is the time that it's really important for staff to look at those resident records and to make sure that they have correct and updated documents on persons' advanced planning wishes. And why is that important? That's important because if someone is in an emergency situation and maybe they have to be transferred out to the hospital, that's not the time to make sure you have those forms signed. You want to make sure that the person's wishes are followed through. And the only way to do that is to make sure you have those advanced planning documents up to date. Next slide. One of the ways, and again, most of you probably already have this, but we thought it was really important to talk about the importance of having a personal information form. Most communities do some sort of a form, and this just gives you a list of things that you might want to include on there. Of course, remembering that this should always be HIPAA compliant. But again, if you have someone in your community that maybe isn't used to providing that one-on-one support for someone, they may not know that person with dementia. And so having an information form that's either on the back of the door or readily accessible in the room so someone knows where to look at that, to give them a good snapshot just to help them. It can just, sometimes it's simple information to know what upsets the person or what calms them down or what some of their daily structures or routines are or what their eating or drinking patterns might be. And then it's also important for the person to sort of quickly know what are their remaining abilities and what are their motor skills. And what are their verbal processing and communications abilities and methods? Because if you don't know that, then you don't know how best to communicate with that person. So if you don't have a form like this, we suggest that you develop one. And if you do have one, to make sure that it's just not sitting in a resident record somewhere or attached to a care plan, that it's out where all staff can easily get that information on each resident. Next slide. A big part of what we're hearing today is the social isolation that's happening, because now we have really changed the dynamic of how residents in nursing homes and assisted living live on a daily basis. For the past 25 years, we've really stressed the importance. And as you all know, as well as I, who've gone through federal and state surveys, one of the things they're looking at is to make sure that residents are up and dressed and out of their rooms all day long and involved in social activities. And now we've totally flipped that, and we're asking them to spend most of their time in their rooms every day, and families and friends are not able to visit. So it's really important that we keep them connected. And so we'll talk a little bit more around some of the technology applications around that. But again, just knowing that that's really, it's one of the things on the top of the list that you have to be concerned about. And again, if you don't have something like a what you need to know fact sheet that not only you have, but all of the residents' family has as well, that has that important information. Ways that the families and friends can reach you if they have a question, ways that you can reach them in time of emergency situations. But also remembering to list things around adaptive devices. So again, if there's someone working maybe on a night shift and someone has an emergency situation and they have to go out to the hospital, then having a form like this where you could have their hearing aids or eyeglasses or dentures, making sure you know those adaptive devices that residents have so they can go with them. And then too, it's just important to remember that each family is unique. And sometimes it's those family members that are really the ones that are most close, but sometimes it's friends or community members as well. And just so honoring to make sure that you're honoring residents' wishes on who is important for them to stay connected with. Next slide. Assisting with eating and drinking is really important. And why is it important? Because we know that people with dementia may not be able to recognize hunger or thirst, and they may need to be prompted or reminded to drink. And so again, this is great information for folks who aren't involved in those activities on a daily basis, and helping them understand that they may need different types of verbal or visual or tactile cues. We know that through work with our dementia care practice recommendations, for instance, that using a graded approach is really appropriate. People with dementia just don't go from being able to feed themselves independently to not being able to feed themselves at all. There's many different levels in between. So staff being able to recognize that, and whether they give them an adaptive device or they're using maybe colored dinnerware to put the food on to help in food intake. There's just different tools and resources that are really important. It's really important that we want people to maintain their strength. So to use that as one of the tools to keep them healthy, to maybe keep them from contracting this virus, but also just so staff can familiarize themselves with the person's eating and drinking patterns and their abilities. We also know that sometimes just sitting and talking with a person with mealtime may improve intake. Again, would love to hear from you today. One of the things that we're hearing is because people are not in those communal dining activities and they're not talking to their friends and watching the modeling behavior from other people eating, food intake is going down. And so I've heard from some communities who really are watching that, and for residents whose food intake is reducing, then they're spending a few minutes with them. And they say just sometimes just spending a few minutes with someone as they have their meal can tremendously improve the amount of food that they're eating. Next slide. And then again, another important area is monitoring walking. We know that walking is a purposeful motor activity. It promotes mobility and it helps in strength building. It also helps in skin integrity. We know that sitting all day long can create those pressure sores and pressure ulcers. So it's important that folks are up and walking. I think we've all been guilty. I know I have, of sort of talking about the wanderers. And, that's such a negative term. I think we're trying to change that language to say it's really talking about walking about, and that's a purposeful activity. So you need to make sure that they have those safe spaces to walk about. And they have that opportunity still to exercise and to get some time to be outdoors in a safe environment. One of the things we've learned through our dementia care practice recommendations is bright light therapy now has a dosage amount. So the correct dosage for someone to get that bright light therapy dosage is to go outside between 9 a.m. and noon for 20 minutes. And if that is something that's important to that person, that's the amount of time that it would take to satisfy that dosage amount. But of course, as always, it's important to remember that they have to have a safe environment to be able to walk about in, not only within the building or without and outside the building as well. And again, just remembering these activities, utilizing those social distancing protocols are important to keep in mind as well. Next slide. So this is one of the most important parts, I believe, of these guidelines, is observing and responding to dementia-related behavior. We know that behavior is a form of nonverbal communication. We know that sometimes these behaviors are simply just a response for the person living with dementia to communicate a feeling, an unmet need, or an intention because they cannot maybe do that, or they think they can't do that in any other way. And again, knowing that people thrive best with a consistent routine, we know that many times now, because their routine is changed, that can trigger that interaction to have them maybe strike out or to become agitated or emotional. So it really is our responsibility to observe and attempt to understand what the person is trying to communicate. Next slide. So we wanted to list, again, just a few of the ways that we think might be good ways to start identifying the root cause of these behaviors. And remembering that it may be that the person is in pain, or they may be hungry, or maybe they're just overstimulated around something that has them out of their routine. So many times they're going to have that difficulty understanding or misinterpreting the environment. And they are going to have difficulty expressing their thoughts or feelings about that. And then the other one that is really, of course, in a lot of people's thoughts right now is around PPE. How important it is to have and wear PPE to keep everyone safe, but also to remember how troubling that can be. And you've probably seen stories like I have where we're now starting to see people that are taking pictures and they're pinning that to their PPE because the residents can't remember or have the ability to see who is taking care of them if they're in that full PPE. So if they have that picture on their gown, then that helps them know that it's their friend who they're used to seeing, taking care of their needs for that time. Next slide. And so some of the strategies that we have in this is, the very first one I think is where we always start. You want to rule out pain, thirst, hunger, or the need to go to the bathroom as your first strategy. Many times that's what the person is trying to tell you. It's also really important to remember to speak in a calm and a low pitched voice to try to reduce the stimulation. And understand that the individual, they're expressing thoughts and feelings that are relative to their own reality. And we know that that may differ from generally acknowledged reality. So through observation and attempted interventions, what you're really trying to do is to meet their needs, to be able to honor their wishes through their care plans, and to understand what those dementia-related behaviors mean, and to know that sometimes it may be because of other past traumas as well. And it's really important that we never physically force the person to do something. Next slide. Just a few other strategies. Sometimes it's simple. Sometimes it's just a matter of offering a favorite food, or sharing photographs or listening to favorite music. I think, I'm a big music lover. I think most people are, and so understanding and knowing what type of music someone likes can really make a difference in their day. One of the things in our dementia care practice recommendations that we talk about is some of these evidence-based therapies. We now know that non-pharmacological approaches work better than giving someone a medication that was never intended to help them for dementia-related behaviors. So we now have evidence that shows us things like aromatherapy or reminiscence therapy or music therapy really do make a difference. And using these tactics based on knowing which one might work for the person can really make a difference in the quality of their life. And then sometimes it's providing purposeful tasks to be helpful. So again, that's a little bit harder to do now because everybody is more situated in their rooms. But, we know as things start to ease back up a little bit and we're going to start seeing things like social distance dining. If there's activities they can help with that, that sometimes is really helpful for those dementia-related behaviors. And then, of course, technology is playing a big piece. The tenets of really how the culture change movement started was helping people with loneliness, helplessness, and boredom. And that's at the center of where we are today. Residents are spending the majority of their time in their rooms. And so those episodes of loneliness, helplessness, and boredom are something we really have to pay attention to. So one of the ways is having technology to have scheduled phone calls or video chats with their friends and family. And there's lots of different applications that are out there. And we're actually working on a grant with Florida right now where we're working with a technology company that's delivering some tablets that are preloaded that have the picture of a person. And all they have to do is to touch that button and that automatically connects them with their friends and families through video chatting. So there's lots of good applications that are out there. And again, since families and friends can't be there to see their loved one or hold their hand, connecting them through technology can certainly help. Next slide. And then just to wind this, a few others that we know sometimes supporting their spiritual needs can make a big difference. Or, just giving them a warm blanket, or if it's a hot day, putting a cool cloth on their neck, or talking to a particular staff person can really make a difference. I remember back when I was an administrator and in the memory care unit, there were several residents there that I knew well, that I had gone to church with and were part of my community. And so if someone was having a particularly bad day, sometimes they would call me just to sit and talk with the person and have some reminiscence with that person. So I think all of us that have worked in this area all develop special relationships. So sometimes just having that special staff person to spend a few minutes with the person in the room can make a real difference. Next slide. And again, just to remind all of us, as I said, we know that non-pharmacological treatments are the first option. We also know in this country, in nursing homes and assisted living, we have a high overuse of antipsychotic medication. Um, the work that CMS has done through the National Partnership to Improve Dementia Care has really helped in nursing homes. And so I don't have those numbers off the top of my head, but I believe when that um, initiative started, around 30% of all residents in long-stay nursing homes were on an antipsychotic medication, and I believe in the past few years that's been cut in half. There's work being done also in assisted living. Dr. Cheryl Zimmerman from the University of North Carolina is working on a study right now, and her initial findings show that around 27% of all assisted living residents are on an antipsychotic medication. So we have a lot of work to do in this area. But if all non-pharmacological treatment options have failed, then that is the time to work with your medical director to um, discuss to see if a pharmacological approach may be the best option. And of course, if it does, really working with the medical director to, once this is implemented, to not only have a start date, but to think about an end date on the front end of this as well. So that person is just not left on that medication indefinitely. The next slide. So our goal in providing these emergency preparedness guidelines, and I just want to say we've been really pleased with how these have been shared. As we were developing them, we reached out to several of our uh, long-term care organizations that are part of our Dementia Care Provider Roundtable to get their feedback on these. We also reached out to all of the associated organizations such as Leading Age and the American Healthcare Association, and NCAL and Argenum and American Seniors Housing, along with many others. And so once you go to the webpage on our website, you will see that we've had 36 organizations and associations that collaborated with us on this and have signed on to endorse these recommendations. So at the end of the day, we believe the best way to apply these strategies is, as much as possible, to provide a consistent routine, to use those person-centered care approaches, to make sure that every interaction or task is an opportunity for engagement, and to really put the person before the task. Next slide. And then the last thing I want to talk to you about today is a new initiative, and this just we released on Monday of this week. One of the things that we felt was really important, and I think most of you who are on this call work with our chapter closely, and you know how passionate we are, not only in our care and support efforts and in our efforts around medical science, but also in our policy and regulatory efforts. And we felt it was really important for the Alzheimer's Association to take a strong stand around 4 areas. And we have released those, and you may have seen we've been getting some national attention through Harry Johns, our CEO, and Rob Egge, our Chief Policy Officer, and getting some national attention to these. And to make sure that you know from the Alzheimer's Association that we support you. So the first of those is testing. So go to the next slide, please. We want to and believe, and again, we know that everything that we're talking about today is not readily available. We believe it should be, but we know that some of these 4 elements are maybe today aspirational, but it's where every community should be. That every nursing home and every assisted living community must have the on-site capability to verify that all residents, staff, and visitors are free of COVID-19, whether they are or are not symptomatic. And so, when we developed these, we talked about the White House standard. Now that we know that, that they're having cases in the White House, maybe that's not the best, but we do know that they have regular and routine testing. And that's what you need as well. Again, just recognizing that you are on the front line of this and all the attention that has been given, rightly so, to the acute care and the hospital systems, but you need that same attention, maybe more so if we look at the number of cases nationally and we look at the number of deaths nationally and you follow that data, it goes straight back to nursing homes and assisted living communities. So the only way that we are going to be effective in controlling that is one of the ways is through testing. Next slide. And so, just what does that testing look like? It's establishing a baseline to begin with, and then making sure that there's a process in place that tests staff and residents appropriately. And so, that is going to mean that we are going to have to make sure that there's not only the availability, but the proper training to train people on how to use these rapid point testings. And then after that, then daily testing is really what's going to be needed. If you come in as a staff person and you're tested negative and you come in and you work your shift, when you go back home and you go into the general public, then that test really becomes worthless until you're tested again when you come back in. We know we have a long way to go there, but that's the type of level of testing we need to make sure that we're. Next slide. And next is around reporting. And we know that this is something that is in process. As of last week, CMS has required that CDC collects this information. They've required that every nursing home, report that through the National Nursing Home Safety Network. And assisted livings, and that varies by state, are encouraged to do it. The latest numbers that I have seen, about 24 hours ago, out of the 15,400 nursing homes in the country, almost 13,000 of nursing homes have registered into that system. So it's working well from the standpoint of getting folks signed up into it. But on the nursing home side, out of the 22,000 assisted living communities around the country, only about 200 of them had started entering data. Transparency is absolutely important. And, one of the things that I would say to all of you is your transparency is very important. And I know sometimes that, you're going to be faced with information that's scary, but it's really important that everyone knows where you stand. And that's only going to make it get better if we all are completely transparent in what's going on in all nursing homes and communities around the country. Next slide. Um, so again, I just think this just reports more out around the reporting, but again, just of course reminding that we have to protect the privacy of individuals, but knowing that we can do that, you can do that. And so having some sort of a publicly accessible web platform that's searchable down to the setting level to make sure that that de-identified data is there, so everyone in your community, everyone that works in your building, everyone that lives in your building, and all other family members know that your reporting is done on a transparent basis. Next slide. The next one is around surge. And, we are starting to hear that some states, Maryland is one that comes to mind since it's close to, where I live. They've really done a pretty good job on sending out these surge teams or these strike teams to help when hotspots occur. We know, and what we've learned in the past few weeks is there really is no one size fits all recipe for this. But we do know that hotspots are popping up. And as those hotspots occur, there's got to be the availability for these strike teams to go in and to help. My philosophy, and again, would love to hear your philosophy on this as well. We know that nursing homes and assisted livings were never designed to deal with a virus as viral as this one. And so you're going to need help, and you should ask for that help. And to be able to manage the infection control procedures that you're having to manage. You sort of raising that call to say, we need some help to get through this, and have these teams to come in to help you if you are a hotspot so you get through that is really important. Next slide. So what does that look like? One of the things is, making sure that the ombudsman and the surveyors have the ability to come in. And, I think it's really important for us to remember, and I think the surveyors really are operating on a philosophy of, this is not the time for them to be punitive. This is not the time for them to come in under their normal survey processes. Naturally, they were going to be focused, as they should be, on infection control procedures, and they should be making recommendations, and if there are egregious activities, writing deficiencies. but really having it more of a proactive approach on how ombudsmen and surveyors can be there to assist you versus being there to wait for you to make a mistake so they can write you up is not going to help anyone in the short term. So just making sure that things around transitions, to make sure that you have the protocols for that. We know that transitions are problematic in normal times for persons with dementia. And so making sure that you have the good procedures and you know how to maintain responsibility as the sending site to make sure that handoff happens and everyone has all the information they need. So when the receiving site takes responsibility, then they have all the information that they need. Next slide. And then finally, around support. There's no way for you to be able to do your job unless you have all the PPE, the testing equipment, and the external support that you need. Next slide. And so if you don't have that PPE, it's really important for, again, you to sound that alarm, that for you to be able to do your job effectively and do the infection control that you have to do, along with the testing that you have to do, to make sure that you have the adequate PPE that you need. And then, of course, just remember that folks with dementia are going to need some special attention. And so make sure that you have the support to take care of them properly is really important. And the next slide. So I'm going to end there and just remind folks that one of the ways we can also help is through our 24/7 helpline. And we mentioned that earlier. We are there with master level clinicians 24/7 in any language. We have interpretation services to help you. And those people are there waiting for the general public. As we said, these are for residents with dementia, people with dementia, their families, their friends, staff that work in communities, and the general public as well. So any time of day, if you have a question, please make sure that you call our helpline. So I will turn it back over and see if we have any Q&A.
Great. Thank you so much, Doug, for your really great information and timely information. I think it's really helpful to kind of gather the troops and hear. We may have heard this before, but now putting it into the situation that we're in is really helpful. This is the second time I've heard Doug present this content, and I've caught a lot more. I've taken a lot of notes, so thank you again for taking the time to share this information. So the first question that we have, and if you do have a question, you want to share a success story, something that has worked well in your senior living community, please share those in the chat and we will go through those. Doug, the first question comes from Marla. I'm going to kind of paraphrase this together. Her question is around the effects of social distancing, mainly keeping family and friends at a distance. And how does that affect those living with dementia, their immune system? She's been doing some research on that. Just wondering, because we know physical connection with family and friends is so important, does this actually make people living with dementia more susceptible to the virus?
Wow. Interesting question. And I'm just going to say I'm not a clinician to be able to answer that, medically. But I think we do know that social isolation has lots of areas where it's detrimental. It has the potential maybe that through someone's immune system, but we also, as we stated, we certainly know that it can increase dementia-related behaviors. And even not even dementia-related behaviors, just behaviors in general. I mean, think about it from the perspective of, I think a lot of us maybe have cabin fever and being in our homes for a long time. But what if you were in one room now for 10 weeks and you got to go out for a day, an hour a day? And actually, we're hearing in some states, California, for instance, in Los Angeles County, they're not allowing residents to go out at all. So 24 hours a day, residents never get outside. So this is going on for 10 weeks. So I think one of the ways that we can really help with this is to repurpose the staff that we have. We are hearing examples of, for instance, that the van driver who is not going anywhere is now an activities person. The office staff is now spending time out in the community, and maybe they're assigned to 2 or 3 residents a day where they know what type of activities they like. And so I think anything that we can do to give more people more contact, the better it will be.
Thank you. Another question that actually came up about a month ago at another webinar Nikki and I were doing was kind of around that same concept of the lack of, well, physical touch, but for those who are working in memory care, working directly with those living with dementia, there are people who, as we know, boundaries are changing and they really crave physical connection. They're the huggers. I'm coming down the hallway and I'm going to give you a hug. There was a question from staff of, well, how do we manage that by still providing person-centered care, but also providing safe care?
Yeah.
How do we manage that? I'd
It's
love to
tough right
know.
now. Yeah, it's
Yeah.
tough. And I think, hopefully if we can get to the point and where we can test daily, and then we know that everyone is negative, then we can go back to life as normal. But we're not there yet. So I think we have to just, we're hearing some communities are doing creative things. They're cohorting all of their staff, and some of the staff are living at the building. So they never, once they're tested negative once, if they're not going out into the general public, then that allows them to have more intimate contact with some of the residents. But right now in the situation we're in, maintaining that social distance is really important. But we also know in memory care units, and again, I hate to use the term huggers, but we all know what that means. We have some residents who just want a hug, and they're used to getting those hugs every day, and they don't understand why they can't get a hug. And so, like I talked about the modeling behavior with hand washing, we may have to start showing them some new types of modeling behavior. So if they come up for us for a hug, we may have to put our arms outreach to them and then put our hand over our heart and then give ourselves a hug to show that we're giving them a hug. Using those type of techniques to help them as best as possible to understand that this social distancing right now and that contact is the reality that we're in, and we know that's not always their reality, so it's really difficult.
And Nate has a question, and I may ask Nate to clarify a little bit. He asked if there are techniques or tools available for staff who wear COVID PPE. Our site is dedicated to COVID-19 care, and we have seen a significant number of residents with dementia, and our team struggles at times because of the PPE barrier. And Nate, if
Yeah.
you want to clarify maybe a little bit more about that barrier, but Doug, go ahead.
Yeah, I think what Nate's saying is sort of what I alluded to. It's scary, right? If people are coming in full PPE, and that includes an N95 mask or maybe a face mask, um, and they don't know who that person is. The other thing that a lot of folks with dementia are hard of hearing. And so not only do they see this person that they don't recognize, the person's talking through all of this equipment and they don't know what they're saying. So I thought the idea of the picture was really one technique that was really good, and just and not having it small like your name tag, but literally blowing it up to a 5x7 or 8x10, putting that on there and making sure it's a picture of you smiling and it's a happy face. And then they can point to that picture when they're coming in to help people remember is one idea.
Good. And Crystal posted a link for um, the clear mask, saying, here's a link for the masks that we're going to order that are clear. They won't replace N95 masks, but they would replace a surgical or cloth mask. So
I've heard about those. Yes, it's a special type of transparent material. Again, they're not N95 rated, but they have the transparent where you can see the person's face. Yeah, I've seen about those.
Nikki, can you move to the next slide with the questions on it as well? Yeah. So we had just some other questions that we wanted to put out there if me maybe spark something that you've been wondering about. And again, we'd love to hear success stories. If you have found a certain mask, like Crystal sharing the clear mask, or if you are using pictures on your mask so people can see who's behind the mask. Please feel free to chat and let us know what you're doing and what has been successful. When I provide education for long-term care facilities, I try to spend time talking about, well, what is working well? Because so often we get down the road of the challenges and what's not working and what's stressful and just tough. But it's also important to celebrate, even in a pandemic, what's working well? What can we share with others, even within our facility, that, hey, I found this works with this person. Please tell everybody. Don't keep that in the binder with the care plan. Tell everyone so you can all share that information.
Well, and I would just add to that, one of the things that's really been great for me is we're running several Project Echo series. Actually, we have one that we're doing with some assisted living communities in Minnesota right now. We had a call with them yesterday. And that's the whole purpose. The purpose of Project Echo is all share, all learn. And it's been good to hear people that have those new ideas that they can share with their other communities to help them in
that. And Doug, if senior living communities are interested in learning more about Project Echo, should they call the helpline, or what's the best place to find more information about participating?
We have a Project Echo section on our website. So if you go under lc.org professionals, where we currently are right now, we're still learning and growing with our Project Echo series. So it's still run out of the home office. Our goal is to eventually be a super hub where we can start pushing that out to the chapters. And we were working on a plan with that till COVID hit, and that sort of slowed that down a little bit. We are, Kendra, I think running a national series. And so we're in the process now of getting that up and going, that are based off of these principles of the emergency care practice recommendations. We started out with one series. We got so much response to that. We're going to have a second series. So both of those series are full, but we're hopeful that we will follow up with another series. So as we do, we'll make sure that you have that information to share with folks.
Great. And like Doug and Nikki have talked about before, our 24/7 helpline is really the best place, or our website. If you have additional questions, or if it's 3 a.m. and you're working overnight and you have a question or something's not working and you just need help brainstorming another strategy, please call that number 24/7. They will be able to link you to a local office of the Alzheimer's Association if that would be appropriate in that situation. So our helpline is really the best way to connect, like Doug said, with experts at any time, night or day. As well, that number is for family members as well. So if you have a family member who's maybe struggling with everything that's going on and they just need somebody to visit with, or somebody to kind of maybe find some strategies for their own self-care and to get through the situation, they are more than welcome to call the helpline to talk to a dementia expert any time of the day or night.
Yeah, and Kendra, I just want to add to that, and say what I said earlier. Please let people know when you need help. It's okay. We know you need help, and ask for it. We're not going to know, and we being the collective we, until we know what type of help you need, we're there to help. We want to do everything we can do to help you. And so reach out. If you face a situation that you can't deal with the staff that you have, then ask for help. And I think there'll be people there to help you.
And we do, speaking for the Minnesota North Dakota chapter, we want to collect that information and pass it on to our public policy folks as well. If there are real life situations or struggles that are common, we want to add that to our collective of policy change as well. So the Alzheimer's Association has many different branches that all work together in really providing help for professional caregivers, family caregivers, those living with dementia on a large-scale policy platform as well, but also on the one-to-one, a phone call with a caregiver, or maybe somebody working in long-term care.
Yeah.
So we're right at 3 o'clock, and on the screen right now you have a link. If you would like a certificate of attendance, you are welcome to follow that link and it will be emailed to you. The handouts of today, they will be sent out tomorrow if you would like those. And there is also 2 different websites. One that's in the chat right now that was on the very first slide. I think, that connects you directly to our website where the COVID specific information is at. And again, if you have any other questions that you want to talk about offline or anything else that might come up, please do call our helpline at any time. With that, thank you again, Doug, for joining us today and sharing your expertise. It is greatly appreciated. And thank you all for taking the hour today to attend. We hope this was helpful, and please look at our website for upcoming other education and support group options as well. Have a wonderful day. Thank you, everyone.
Thank you, everyone.